Hey guys, so today is day 2 of our PROLOG quiz series. We're going to be continuing on with GYN and surgery topics. So let's get started. So the first question has to deal with a 39-year-old nullogravid woman with a history of irregular and heavy menses. She's hoping for future fertility. She has a pelvic exam that's unremarkable. You do a pelvic ultrasound, and that shows a thickened endometrial lining. You then sample her endometrial lining, and that comes back as complex atypical hyperplasia. And so the question is, what do you do? And so most of you got this correct. The correct answer is the levonorgestrel IUD or the Mirena IUD. The other options are not correct because, for example, laparoscopic total hysterectomy would be inappropriate in a woman who still desires childbearing. Combined oral contraceptives is just a kind of a red herring. And then it's not appropriate if you are going to do a hysterectomy to leave the cervix in place when you're dealing with endometrial cancer or endometrial hyperplasia. And so let's talk a little bit about what is complex endometrial hyperplasia. And so we all know that endometrial cancer is the most common GYN cancer. It is caused by unopposed estrogen. And there are two major classification systems for this. And so the one that we are the most familiar with is EIN. And that's the one that's endorsed by our societies, for example, SGO. But there is another classification system that people are moving further and further away from, and that's the 1994 World Health Organization schema, or the WHO 94. So we will talk about both of these briefly. And so the WHO 94 has 4 classifications. So the first is simple hyperplasia, which has less than a 1% chance of progressing to malignancy. Complex hyperplasia, which has about a 3% chance. Simple hyperplasia with atypia, about 8%, and then complex hyperplasia with atypia, which has about a 30% chance of progressing to malignancy. And this is obviously the most concerning lesion. And so when you think about atypical hyperplasia, you should be thinking about precancerous potential. Those things should be kind of paired in your mind. And the way that this classification system works is based on examination of glandular complexity and nuclear atypia. However, there's a lot of inter-observer variability, and so the system was found to be not as reproducible, and that's why we've moved more towards EIN. This schematic is showing examples of the WHO classification system and what representative samples might look like as you're kind of progressing down that classification. And so at the top we have normal proliferative endometrium. And then below it on the left is simple hyperplasia. And so you can see that there are overall appears to be more cells, but everything looks overall normal. The glands are not abnormal. There's not an excessive amount of glandular crowding. Contrast this with complex hyperplasia. And then simple hyperplasia with atypia. And so you start to see here disordered nuclei, and then of course the most obvious example is complex hyperplasia with atypia, where you see lots of cells, lots of glandular crowding, lots of really hyperchromatic nuclei, and just looks very abnormal compared to your normal proliferative endometrium. So now let's discuss the EIN classification system. This is the one that we use at the BI and that everyone is more familiar with. And so there are 3 classifications. The first is benign endometrial hyperplasia. These are benign diffuse changes caused by prolonged estrogen effect. These can be treated with hormonal therapy if a patient is symptomatic. You can think about this as we have patients where we get this result all the time back on an endometrial biopsy. This is not EIN, this is not endometrial cancer, but this is someone who has lots of risk factors for endometrial hyperplasia. And we might, for example, suggest putting in a Mirena IUD in order to prevent progression of the abnormality of the endometrial lining. Contrast this with endometrial endothelial neoplasia. This is EIN. This is a precancerous lesion, and we treat this very similar to how we treat endometrial cancer. In a woman who desires future childbearing, it's not unreasonable to offer her hormonal therapy. in the form of high-dose progesterones and a Mirena IUD. Often we're doing both. Or in a woman who is done with childbearing, definitive management with in the form of a hysterectomy can also be offered upon diagnosis. And then the last one is endometrial adenocarcinoma. So this is endometrial cancer, one type of endometrial cancer. So this is endometrioid type. This is the most common type of endometrial cancer, distinguishing this from the serous type, which we will not discuss today. I like this little schematic because it kind of, in my mind, just solidifies, how the endometrial lining can progress from this benign endometrial hyperplasia to a precancerous lesion to finally a carcinoma. So just starting on the left side, these are, imagine these are your endometrial cells, and you have lots of estrogen, and that's promoting hyperplasia and growth of the endometrial lining and overgrowth. Now, if one of these cells were to develop a mutation that allows for clonal expansion, then this will produce a lesion. This would produce an EIN lesion. And then once those, clonal cells develop more and more mutations, that increases the probability that you're going to progress to a true carcinoma, which is invasive. I have a few additional diagrams we can talk about very quickly, just looking at different types of endometrium. So this is just disordered proliferative endometrium with some mild estrogen effect. Overall, this is normal. Contrast this with a moderate estrogen effect, and so you can see there are a lot more glands. This is benign endometrial hyperplasia. Again, overall, the morphology is normal. However, the gland density is higher. Now contrast this with a localized EIN lesion, and so you can see that on this side of the image, these glands are very dense. They overall look crowded. It looks very different than what we saw on the previous slides. And then on this side, there's like a little pocket of normal endometrium that you can use to contrast. Continuing to progress along the cascade of atypia, this is a EIN lesion, and so you see a little bit of normal endometrium on the right, and then this highly abnormal area over here. And last, you see endometrial adenocarcinoma, endometrioid type. The glands are no longer visible individually. It just looks like a bunch of glands. It's lost its overall, architecture, and so this is a endometrial cancer. And this is just a higher magnification view of some of the cribriform glands seen in well-differentiated endometrial carcinoma. So as we were discussing in the kind of review and learn, or I don't know what the name is called now, but our board review sessions, there's a high rate of cancer that is found in atypical hyperplasia. This is important for you guys to know. That is why we treat them very similar. Approximately 40% of patients with a complex atypical hyperplasia is found to have carcinoma diagnosed on hysterectomy, and so you can just replace this with EIN. Although the PROLOG still use the old nomenclature, so that's kind of why I'm using it as well. But what if you have a woman who desires future fertility? What do you do? And so you can treat her with high-dose progesterone or an IUD or a combination of both, which I've seen more common that people are doing both. And so the regression rates with oral progesterone, as quoted in the PROLOG, answer document, is approximately 70%, although I've seen higher rates being reported, and 90% with a levonorgestrel IUD. And so there is a good chance that you could potentially, at least temporarily, make this lesion go away, although eventually the woman will need definitive management of her EIN. So this is not a cure. She does need to have her uterus out, but this might give her the opportunity to complete childbearing. And so, but we just don't, leave these women just to kind of hang out with their EIN without seeing if the medication or the treatment is working. And so these women will need serial endometrial sampling every 3 to 6 months. And that can be performed with the IUD in site. I included this table from the answer document that's provided with the PROLOG series, which all of you have, by the way. So none of this is new. You have access to everything. And so this is just talking about different acceptable hormonal treatment for EIN. And they're also going back and forth in the guidelines, so it's a little bit confusing, but they say EIN here, previously known as atypical endometrial hyperplasia. And so the ones I've seen most commonly used are obviously the IUD that we talked about, and then Megace, but there are, protocols for using medroxyprogesterone acetate, depot medroxyprogesterone, or even micronized vaginal progesterone, which I wasn't aware of. All right, so that's enough on that topic. We're now going to progress to question 2, so switching gears completely. Question 2 has to do with a 68-year-old woman who is coming to your office with new onset urinary frequency and loss of urine for the past month. Her primary care physician has started her on an anti-muscarinic agent. However, she's not getting better. She is a tobacco user, has completed radiation therapy for cervical cancer 20 years ago. She has a urinalysis, which is notable for microscopic hematuria. What is the next best step? And so I think the first thing is to highlight what are the things that you should be cued into that should make you think that there's something more that we need to do. So the first thing is that this is new onset. It's not really appropriate for her to be put on treatment without first undergoing a workup. So this is not ideal, but whatever, the patients will come in being started on inappropriate treatments all the time, and you need to be able to, interpret their symptoms in the setting of that. She also has a lot of risk factors for just badness. So she's a tobacco user, she's had radiation therapy, and again, this is like a very sudden progression, and so she needs further workup. And so the correct answer for this is a cystoscopy. So a cystoscopy, we are all familiar with this. We do it often in the operating room after, let's say, a hysterectomy. But you will see if you've rotated in Urogyn clinic already, or if you will do that in the future, that they do it often, in their clinic as well. And so the cystoscopy actually provides a lot of information. It allows you to assess for any lesions, any defects of the bladder. You can assess the ureters. Not really applicable in this particular question, but the cystoscopy is an easy, low risk way of evaluating the lower urinary tract, and so often that's going to be your correct answer. And so I wanted to briefly talk about evaluation of microscopic hematuria, although we're going to talk about it in greater depth at a later time, because I think this is a topic that we don't get a lot of formal teaching in, but it's important because we're often getting urinalyses, and we need to know what to do when they're abnormal and when patients, especially if they have risk factors for things like a bladder cancer or another type of malignancy that might be invading into the bladder, what do we do? And so just think first about the patient. She has multiple risk factors for pathology. She's had radiation exposure before, so she could have a delayed radiation cystitis that's just manifesting very late. She has a history of cervical cancer, and so could this be recurrence of a cervical cancer, and she's actually has invasion into the bladder. She's a smoker, she's at risk for a primary bladder cancer. And then also what's weird is that this is new onset, like she just woke up one day and developed a issue, which would make you think that there's something suspicious going on. So it's not appropriate to just treat her. We do need to work her up. So whenever you're evaluating microscopic hematuria, the first step is to start with a urinalysis, and this will help exclude common things. So does this patient have a UTI? Does this patient have a risk factors for stones? What are their presenting symptoms, etc. And then if the common things are not positive, then the next step would be for evaluation of the lower urinary tract with a cystoscopy. But what about the other methods that they mentioned in the answer responses? And so they talk about renal ultrasonography, they talk about CT urogram, intravenous pyelogram, and avoiding cystogram. And so we have intermittent exposure to each of these different tools. We order them sometimes on our patients depending on what their presenting symptoms are, but I thought that this would be a good opportunity to just talk very briefly about each and then what they're evaluating for. So the most common we get is a renal ultrasound. We get these very commonly. This will help us evaluate the upper urinary tract. We can look at kidney size. We can evaluate for hydronephrosis. We can look for obstruction, like in the form of stones. But this will not I apologize, I advanced the slide. It will not help us evaluate the lower urinary tract system, which is what we need to do for this patient. The other method is a CT urogram, and so we get this, I would say every few months a patient's having a CT urogram, but why a CT urogram? Why not another imaging test? Well, this is actually the preferred modality if you want to evaluate the upper urinary tract. You can do it with or without contrast. The benefit is that you can get a really good examination of the renal anatomy. So without allows you to evaluate for stones and obstructions, and then with you can examine the renal anatomy, you can look for masses, you can look at the path of the ureter. Our next one is an intravenous pyelogram. We get this very rarely, but this is a good technique for evaluating the patency of the ureters. And then the last one is avoiding cystogram. And so this is good for evaluating for bladder defects, checking, for example, checking the integrity of a cystotomy after a repair. And so you actually do the imaging tests while the patient is actively voiding. I tried to put a few videos here, but it didn't work, but you guys can Google them. And, they're kind of cool to watch. So this picture is a normal one, this one on the left. And then this second picture is an example of a neurogenic bladder. You can see this is like wildly abnormal compared to this. All right, moving right along. So question 3 has to do with a 30-year-old woman who is in the middle of a surgery. We're taking out a large complex adnexal mass. We know she's allergic to penicillin, but she's otherwise healthy. She's not obese. You give her some cephalexin. Upon entering the abdomen, the anesthesia team is very stressed and alarmed, and they tell you that the patient's blood pressure is 60/30. She's tachycardic, her heart is beating 130 beats per minute, and she's dropping her oxygen saturation. Uh-oh, what's happening? And so this is not something that we're commonly having to face with, but we should be aware of what the possibilities are. And so the anesthesiologist would give her a bolus of fluid, and then what is the next best step to for them to administer? And so we kind of have to think about what is going on. And so the options they give us are broad spectrum antibiotics, blood products, epinephrine, heparin, and hydrocortisone. And so for broad spectrum antibiotics, we don't think that she is at induction of anesthesia now become floridly septic. No, that's not the right option. Is she bleeding? And so we're in the abdomen operating. It's unlikely that if she is bleeding, that we would not, see the evidence of that massive hemorrhage. And so that's, again, unlikely. Epinephrine, that's an interesting concept. We not often in the situation of giving it, but, let's put that in our back pocket. Heparin, well, why would I give her heparin? Do I think she has formed a huge, saddle PE? Unlikely. And then the last one is hydrocortisone. And so do I think she's in an adrenal crisis and that's what's happening? And so, again, this is just unlikely. And so the answer ends up being, just by process of elimination, you can kind of off the bat say that these two are probably unlikely. I don't think she has a DVT, and I don't think she's going into adrenal crisis. If they is, this is a very unfair question because they gave us no indication of that. She's otherwise healthy, not obese, like she's not chronically on steroids. And so by process of elimination, you're giving her epinephrine, and the question is why. And so I think the things that you know to highlight in this question are the initial thing that she's allergic to penicillin. They really didn't talk about in the question stem if we inquired what that allergy was. And we know that there is an ability to have cross-reactivity with cephalosporins with patients with severe penicillin allergy. So, we gave her severe anaphylaxis. And so the treatment for that is one of the mainstays is epinephrine. So let's talk a little bit more about that. This is taken directly from the PROLOG answer series, and you should all just look at it very quickly and gather whatever information you can get from it. I wouldn't perseverate over it. But they, reading through and preparing for, these answer solutions, I learned a little bit about, how to evaluate anaphylaxis in a more systematic way. We kind of all have a gestalt of when someone is having an allergic reaction, but there is a table that the World Allergy Organization has provided us. And so the first is when a person has acute onset of an illness, so minutes to several hours with involvement of the skin, mucosal tissues. So we think about generalized urticaria, itching, flushing, swollen lips, tongue, uvula. So this is what we think about typically when someone, has a severe allergy. And then you need at least one of the following. So respiratory compromise, which is, if I were to ask most people, they would, get that one. But what I don't always think about is reduced blood pressure or associated symptoms of end organ damage. So complete, cardiovascular collapse. And so that's another thing to just bear in mind. You're ventilating a patient, they're on a respirator. This might actually be what you see before you see the respiratory compromise, because you already have that person intubated. For example, if the patient had an allergic reaction while in the operating room. Or you can have two or more of the following. And so, again, involvement of skin, mucosal tissue, respiratory compromise, reduced blood pressure, or persistent gastrointestinal symptoms. That's interesting. So cramping, abdominal pain, vomiting. So that's a little bit more subtle. Or reduced blood pressure after exposure to a known allergen. And so you can see that in infants and children, that they have greater than a 30% decrease in their systolic blood pressure, or in adults where you see systolic blood pressure is less than 90 millimeters mercury or greater than 30% decrease from that patient's baseline. And so again, not something to really spend a lot of time studying, but, just read it over if you have a little bit of time, or just listen to what I've told you, and hopefully some of this sticks. The next table I included show grades of severity of a hypersensitivity reaction during anesthesia and different treatment recommendations. And so, the most localized reactions are just going to be cutaneous. So you're going to get generalized erythema, urticaria, angioedema. For these patients, administering 100% oxygen, withdrawing the suspected agent, so they're not going to get any more of that, that particular antibiotic. And then they just have different, increasing levels of severity. And so, they talk about not life-threatening symptoms, but you are starting to see some hemodynamic changes. And then to the life-threatening, and then, someone going into cardiovascular arrest. So again, not to, belabor this, but giving them oxygen, epinephrine, repeating this one to every 2 minutes. You can put them on an epinephrine infusion. And then, epinephrine, if you look, is a part of all parts except in the most benign reactions. All right, last question. Question number 4. And so we'll do this a little bit more briefly. And so this person had uncomplicated total vaginal hysterectomy. She has OSA. We see that commonly. You get an urgent page to the GYN pager. Oh my God, this patient is desatting. When you go and see the patient, she looks fine. She has a normal heart rate. She has normal blood pressure. She has a ventilation rate of about 13. You put some oxygen on her. Her oxygen saturation improves. What is happening? And so the most likely reason for oxygen desaturation, most people, again, got this one correct. Is it her BMI? Well, her BMI is contributing, but it's not the BMI itself. Is it Toradol? Toradol doesn't make people desat. Is it morphine? This is interesting. You know, obese patient, OSA, giving them a PCA. Could that be it? Potentially. Is it her physical positioning? No, she's not doing anything that would make me suspect that she's going to desaturate. And does she have a pulmonary embolism? So this is possible. However, there are things that make you, rule against this. So the fact that she has a normal heart rate, the fact that it, improves with oxygen. Although, if someone has a PE, you would expect, improvement with oxygen. But overall, the more likely answer is that this is being caused by respiratory depression from administration of opiates. And the thing that kind of should really point you in that direction is that she has a PCA, so she's managing her pain with the patient-controlled morphine infusion, which includes a basal rate. And so most of the time when we give a PCA, we do not do a basal rate. We just have the patient continue to administer the medication as often as as your instructions will allow. So you will set a lockout rate. It's typically like every 6 minutes or so. But a basal infusion means there's a certain amount of narcotic that is going in, even if the patient's not pressing. So if the patient's falling asleep, they're still receiving narcotic. And that could be very dangerous in a patient who's opioid naive. And so that is the better answer for this question, is that she's getting a morphine infusion in a patient who has already risk factors for oxygen desaturations when she sleeps. And so to talk very briefly about perioperative pulmonary complications, we know that patients with OSA are at risk for oversedation with narcotics. In general, interns, when you're writing PCA instructions, you should avoid continuous infusions. There are some settings in which you will give that. Let's say a patient is on hospice, or it's a cancer patient who's getting like chronic opioids for for very severe, end stage pain. There might be a setting where it's appropriate to give a continuous infusion, but that's very rare, and we don't typically take care of those patients. Those patients are usually on OMED. And then just be aware that patients with OSA have a higher risk of increased perioperative complications. Okay, so that was a lot. Hopefully the next ones will be a little shorter. They had 4 questions, which I think had a lot of material. So coming soon, we're going to try to do an endometrial cancer review, and then also more information on urinary continence, and then urogyn topics. All right, thank you, everyone.